Hello, my name is Trent Davis. I am a second-year osteopathic medical student at OUHCOM. My presentation is entitled Imageless Robotic-assisted Total Knee Arthroplasty, Association between Preimplant Balancing and Manipulation under Anesthesia. Arthrofibrosis is a common complication following total knee replacement, with a reported prevalence as high as 11%. It occurs due to articular scar tissue formation, which causes a painful loss of range of motion that interferes with the patient's activities of daily living. Manipulation under anesthesia is a specific indicated procedure when patients are unable to achieve flexion past 90 degrees and have failed to respond to conservative treatment by 6 weeks. Gap balancing is a specific complex step in implant positioning that may impact the development of arthrofibrosis as an indication for manipulation under anesthesia. Gap balancing refers to the relative distance between the femoral condyle and tibial component in the coronal plane from extension to flexion. The leading thought popularized by Insall and colleagues was that the medial and lateral gap should both measure 2 millimeters to create a rectangular gap in both extension and flexion. The representation at the right of the screen demonstrates post-cut rectangular gaps for a hinge-based model of the knee. However, native knee gaps are not necessarily rectangular. Additionally, the unscrewing mechanism is critical for proper articular alignment during flexion, indicating that it is not purely a hinge movement. The lateral compartment is more mobile around a medial pivot point. At the beginning of flexion from full extension, the lateral femur externally rotates on the tibia around the medial compartment. The knee unlocks from the position in full extension to promote proper tracking of the condyles on the plateau in mid to deep flexion. During Navio Imageless Robotic-assisted TKA, the surgeon can modify cut thickness, rotation, and alignment to modify the gap balancing plan. Robotic-assisted technology with the Navio allows for storage of operative variables which are not often measured or saved in conventional TKA. One specific aim of our study were gap balancing planning parameters associated with arthrofibrosis. Potentially, decreased lateral gap and less imbalance in extension is associated with manipulation under anesthesia due to arthrofibrosis, as that would eliminate the unscrewing mechanism of the knee. Our study was retrospective in design, in which 2 surgeons performed Navio TKA within the Mercy Health Toledo system. 300 procedures were performed in the first 2 years of its inception. 265 Navio TKAs were included in the study. 23, or 8.7% of patients, required manipulation under anesthesia. We discovered a significant difference in the lateral gap and extension and planned imbalance in extension between patients that required manipulation under anesthesia and those that did not. The lateral gap and extension was significantly smaller in patients who developed arthrofibrosis requiring manipulation at 1.14 millimeters in comparison to those who did not, at 1.92 millimeters. And additionally, the planned imbalance in extension, calculated by the difference between the lateral and medial gaps both in extension, was significantly smaller in those that required manipulation at 0.483 millimeters in comparison to those that did not at 2.02 millimeters. Our results indicate that decreased lateral gap at extension and less lateral to medial imbalance in extension decreased femoral external rotation during early flexion, resulting in restriction in flexion or the primary formation of scar tissue, creating arthrofibrosis requiring manipulation under anesthesia. This instance would be most consistent with a rectangular gap balance. Our findings suggest that ideal gap balance retains native femoral external rotation during early flexion by having native gap balancing alignment. This would cause no restriction in flexion and decrease complications like arthrofibrosis, ultimately increasing patient satisfaction. As osteopaths, we are trained to consider the relationship between structure and function. The future of total knee replacement with robotic assistance will allow orthopedic surgeons to integrate the patient's native structure to provide more precise and accurate restoration of optimum function. Thank you.